చెల్లకి ఏం లేవు.
Right, so very good evening everyone. I welcome you all to this particular session on the YouTube. So we at Arise Medical Academy have come up with the sessions which will be useful for your upcoming FMGE exam. So in this session particularly, I have included both image-based and as well as clinical-based questions. So I'll be discussing some image-based questions and I'll be also discussing some clinical-based questions in your general medicine. So I'll also be teaching you in the general medicine how to approach to a clinical-based question. That is also very, very important. Okay. So now let us start with the first question. Okay. Most common cause of unilateral condition of the foot shown in the photograph is pregnancy, lymphedema, venous insufficiency, Milroy disease. So this is your normal foot and this is your abnormal foot. So please tell me what is the diagnosis? Any one of you who will be the first person to attempt the question? So what is this basically now? It is a clinical scenario where there is unilateral edema, right? Where there is presence of the unilateral edema. Where will you see this most commonly? So, no, not Milroy disease. Yes, Harish Srinivasan, you have answered Milroy disease. Can you tell me what is Milroy disease? Any one of you? What is Milroy disease? Okay, so the answer to this question is venous insufficiency. So in venous insufficiency, you will have the presence of the unilateral edema, right? Now, let me discuss about in pregnancy, it's a physiological edema and that too you will have bilateral. Okay? Now, this Milroy disease and as well as lymphedema, both are same. Right? Milroy disease and as well as lymphedema, both are one and the same. Now, what is that? Milroy disease, it's a condition that affects the normal functioning of the lymphatic system. Right? It is a condition that affects the normal functioning of the lymphatic system. So what does the lymphatic system produce? What does the lymphatic system do? Lymphatic system produces and transports the fluid and immune cells throughout the body. Right? The lymphatic cells produces and transports the fluid and immune cells throughout the body. Now, in case of Milroy disease, what will happen? There is impaired transportation of this particular lymph with accumulation of the lymph fluid. So that will make the individual to develop what is called lymphedema. Right? That will make the individual to develop what is called lymphedema. Okay. So now, in case of Milroy disease is nothing but lymphedema, and it can present bilaterally also, right? It can present with bilateral edema also. But in case of the venous insufficiency, this can make the individual, like example of venous insufficiency is what? The example of venous insufficiency is deep vein thrombosis. So whenever there is a deep vein thrombosis, the venous drainage of the lower limb does not go to the inferior vena cava, and thereby there can be accumulation and making the individual to develop the edema. So in venous insufficiency, you will have this unilateral edema very commonly. Okay, so the answer in this question is C, right? It is not your B or it is not your D. Now, so after having discussed about the image based question, next let me discuss the clinical based question. Okay, right. So the question looks very lengthy, but the answer is very simple. Okay, right. Now you see here, we have a right. So we have a 19-year-old recent immigrant from Ethiopia. Right. So how much is the age? 19 years. So he comes to you, your clinic, to establish the primary care, and he currently feels well. So presently he is normal. Right. Presently he is normal. Her past medical history is notable for recent admission to the hospital for the new onset atrial fibrillation. So what is the past history? Known case of the AF, right? So that means for the episode of atrial fibrillation, the individual got admitted in the hospital. As a child, what is the age now? 19 years. As a child in Ethiopia, she developed an illness that caused uncontrolled failing of her limbs and tongue lasting approximately 1 month, right? So uncontrolled failing of her limbs and tongue lasting approximately 1 month. She also had 3 episodes of migratory large joint arthritis. So the other past history is migratory arthritis. And how many times did she get in during the childhood? She almost got 3 times, 3 episodes. Okay, and resolved with pills that she received from the pharmacy. She is currently taking metoprolol and warfarin and has no drug allergies. So presently, what is the drug history? Metoprolol, and she is also taking warfarin. Okay, now, where is that? Yes, physical examination reveals irregular heartbeat with normal blood pressure. That means the individual is in atrial fibrillation. Because in atrial fibrillation, you will have irregular heartbeat. Her point of maximum impulse is most prominent at the mid-clavicular line, is normal in size. So point of maximum impulse in the sense apex beat. Apex beat is in the normal position. Right, apex beat is in the normal position. So an early diastolic rumble and 3/6 holosystolic murmur are heard at the apex. So on auscultation, what is the murmurs you are getting there? Early diastolic murmur is there, right? And there is also the pansystolic murmur, right? A soft early diastolic murmur is also heard at the left third intercostal space, and you refer her to the cardiologist for evaluation of the valve replacement and echocardiography. What other intervention might you consider at this time? So what is the diagnosis first of all? Okay, the options are daily aspirin, daily doxycycline, low dose corticosteroids, monthly penicillin G injections, penicillin G injections as needed for all sore throats. Yes, so very good. So Chaitanya Gampa has answered it very correctly. Very good, Chaitanya Gampa. So this particular patient is suffering with rheumatic fever. Right? This patient is suffering with rheumatic fever. Now, any one of you, please tell me in which clinical condition you will have early diastolic murmur, and in which clinical condition you will have pansystolic murmur. Any one of you, please. What is the clinical condition where you will have early diastolic murmur? What is the clinical condition where you will have pansystolic murmur? Yes. Early diastolic murmur, you will have this in aortic regurgitation. Pansystolic murmur, you will have this in mitral regurgitation. Okay, so this is a classical case of rheumatic fever with valvular involvement. So in these patients, what you need to do additionally, the additional intervention is that you need to give monthly penicillin G injections, right? Monthly penicillin G injections. Now, let me tell you about this monthly penicillin G injections. If you take this rheumatic fever, why you should give monthly penicillin G injections? Let me explain you. Remember, this particular rheumatic fever, it is a recurrent disorder. Right? It is a recurrent disorder. Right. So if you take this rheumatic fever, it is a recurrent disease. Now, this, in order to reduce this recurrence, right, in order to reduce the recurrence, you need to give the injection benzathine penicillin. Right, you need to give injection benzathine penicillin. Okay. Now, what is the dosage of this injection benzathine penicillin? The dosage is 1.2 million units, and you have to give every 3 weeks. Right, you have to give this every 3 weeks. But the dose and the route of administration is intramuscular route of administration. Right, intramuscular route of administration. And if the weight of the individual, for suppose, if the weight of the individual is less than 27 kgs, the dosage of benzathine penicillin is 0.6 million units for every 3 weeks or 21 days. Okay, so why you should give that? In order to prevent the recurrence. So what is the diagnosis? The diagnosis is rheumatic fever. Okay, now I will ask you some more questions on this rheumatic fever. Now this patient had migratory large joint arthritis, right? What is the drug of choice for migratory large joint arthritis in these patients? Any one of you? What is the drug of choice for migratory large joint arthritis in this clinical scenario of rheumatic fever? Yes, in this clinical scenario of rheumatic fever, what is the drug of choice for migratory large joint arthritis? Any one of you, please? So the drug of choice for migratory large joint arthritis, very good. So you need to give high dose aspirin, right? You need to give high dose aspirin, and this high dose aspirin should be given until the ESR is normalized. And in those individuals who are refractory to aspirin, that means if this migratory large joint arthritis is not responding, in such clinical scenario, the patient can be given corticosteroids. Right? The patient can be given corticosteroids. Okay. Now, the other point is, why is this patient taking metoprolol and as well as warfarin? Any one of you? Why is our patient taking metoprolol and warfarin? Yes, why is our patient taking metoprolol and warfarin? Yes, who will be the first person to answer this question? No, not because of the carditis. This patient is taking metoprolol and warfarin for atrial fibrillation. Right, for atrial fibrillation. So for atrial fibrillation, for rate control, right, for rate control, we give beta blockers, and in order to prevent the clot formation, right, in order to prevent the clot formation, we give the warfarin, right? In order to prevent the clot formation, we give the warfarin. Okay, so that is about why we need to give warfarin. And sir, why are you worried about the clot here? Why? Because as a child in Ethiopia, she developed an illness that caused uncontrollable failing of her limbs and tongue, approximately lasting for nearly around 1 month. What does that mean? This individual might have had an embolic stroke, right? The individual might have had an embolic stroke. And why is this embolus formation? Because in patients with atrial fibrillation, the atria does not contract completely, and there will be stasis of the blood within the atria. And because of that, there can be clot formation. Because of the clot formation, if it ruptures, it can shower an emboli, resulting in the cardioembolic stroke. And in order to prevent further strokes, you have to give warfarin in these patients. Okay, so that is about the clinical scenario of acute rheumatic fever and treatment. So for migratory large joint arthritis, drug of choice is aspirin. If the individual is refractory, you need to give corticosteroids. And in order to prevent the recurrence of the rheumatic fever caused by group A beta hemolytic streptococci, you need to give the injection benzathine penicillin. And that injection benzathine penicillin should be given 1.2 million units deep intramuscularly every 21 days. It has to be given. And if the weight of the individual is less than 27 kg, you need to give 0.6 million units. Okay, right. Now, we will move on to the next question. Yes, Arya Ajesh. So in this patient, now why did he come? Currently, he feels well. Currently, he feels well. So when currently he feels well, why do you want to give aspirin in this patient? Don't give any aspirin when he is currently well. Okay, so please don't give aspirin in this scenario. No, in place of warfarin, we cannot give in place of warfarin, we cannot give aspirin in this patient because he is the patient at a high risk for the development of the cardioembolic stroke. So in high risk patients, we need to definitely give anticoagulants. Sir, why are you telling high risk patient? Because already he had one episode of cardioembolic stroke previously. There is high chance further he can develop. So that is the reason why you need to give warfarin only, not the aspirin. Okay. Yes, Arya Ajesh, is that clear? Now, we will move on to the next question. Yes. Diagnose the underlying medical disorder by ECG change in the photograph. Hypokalemia, hyperkalemia, hypercalcemia, hypocalcemia. Diagnose the underlying medical disorder by ECG change in photograph. Hypokalemia, hyperkalemia, hypercalcemia, hypocalcemia. So first of all, you should be able to diagnose what is the ECG abnormality. You should be able to diagnose what is the ECG abnormality. Yes, Harish Srinivasan, what is the ECG abnormality? So, the ECG abnormality here is QT prolongation. Right, the ECG abnormality is the QT prolongation. That is the ECG abnormality. Now, how much is the normal QT interval? Normal QT interval is 380 to 440 milliseconds. Right, 380 to 440 milliseconds. That is a normal QT interval. Now, if the QT interval, if it is more than 460 milliseconds, even though it is 440, the cutoff what we can take is up to 460. If the QT interval is more than 460 milliseconds, this is called as long QT interval. Right, this is called as the long QT interval. Okay, now in those individuals with long QT interval, they are prone for the development of polymorphic ventricular tachycardia. Right, there is high chance of development of polymorphic VT. Okay, and this polymorphic VT, this we call it as, right, this we call it as, any one of you? What is this polymorphic VT called? Torsades de Pointes. Very good. Right, torsades de Pointes. Now, if you see the drug of choice for polymorphic VT, the drug of choice for the polymorphic VT is 1 milligram of magnesium sulfate. Right, 1 milligram of magnesium sulfate. So that is a drug of choice for torsades de Pointes or the polymorphic VT. Now we will go back to the ECG complex, which are okay. And one more condition, one more thing is, what are the electrolyte abnormalities where you will have long QT interval? You will have long QT interval in hypocalcemia. You will have long QT interval in hypomagnesemia. Occasionally, you can also have long QT interval even in hypokalemia. But the hypocalcemia is most common, or hypomagnesemia is most common. But hypokalemia causing long QT interval is little rare, but it can happen. Right? But it can happen. So now, if you take the QT interval in this patient, you see, this is the Q wave. Right, this is the Q wave, the onset of the Q wave, and this is the end of the T wave. Right, this is the end of the T wave. So this is what is your QT interval. So how many boxes do you have this QT now? So you have totally 3 large boxes. Right, you have totally 3 large boxes. One large box is nearly around how many milliseconds? It is 200 milliseconds is your one large box. So 200 milliseconds multiplied by 3, how much it becomes? 600 milliseconds. Right, it becomes around 600 milliseconds. So the QT interval which is in this patient is 600 milliseconds. That means what? It is a prolonged QT interval. Where will you see that? You will see that in patients with hypocalcemia. You will see that in patients with hypocalcemia. All right, next. Now, let me tell you what are the very important ECG changes in other electrolyte abnormalities which are given to you here. So, if you take hypokalemia, the very important electrolyte abnormality is the appearance of the U wave, and the T wave, it becomes flat. Right, the T wave, it becomes flat. Okay, so that is what you see in case of hypokalemia. T wave, it becomes flat or inverted. Right, T wave, it becomes flat or inverted. Then you take hyperkalemia. In hyperkalemia, you will have tall tented T wave. Right, you will have tall tented T wave. Okay, right. And you take in hypercalcemia. In hypercalcemia, you will have short QT interval. Right, you will have short QT interval. That means if you take the QT interval, it will be less than 360 milliseconds. Right, less than 360 milliseconds. Whereas in hypocalcemia, you will have long QT interval. right? In hypocalcemia, you will have long QT interval. Okay, so these are the ECG changes what you will have in various electrolyte abnormalities, and the ECG which is given to us is long QT interval. It is your long QT interval. Okay, right. Now we will move on to the next clinical based question. Yes. A patient with a diagnosis of scleroderma who has diffuse cutaneous involvement presents with malignant hypertension, oliguria, edema, hemolytic anemia, and renal failure. And you have made a diagnosis of scleroderma renal crisis. Which one of the following is recommended treatment in this patient? Captopril, carvedilol, clonidine, diltiazem, nitroprusside. So what is that you want to give in this patient? So if you see the scleroderma, we have two forms of scleroderma, right? Definitely it's an autoimmune disease. Right? Definitely it's an autoimmune disease. Very good. Very good, Guludugar. The answer is the captopril. The answer is the captopril. Okay. So now scleroderma we have in two forms. One, we have what is called localized or limited scleroderma. Right? Localized or limited scleroderma. And the other one is the diffuse scleroderma. Okay, now given case scenario is diffuse, and in case of diffuse scleroderma there is high chance of, that means faster progression of the visceral involvement also, right? There is faster progression of the visceral involvement also, right? And in our patient you can see there is malignant hypertension, oliguria is there, edema is there, hemolytic anemia is there, and renal failure is also there. So in case of scleroderma renal crisis, remember the drug of choice will be AC inhibitors. Right? The drug of choice will be AC inhibitors. And among the options given to you, what is the AC inhibitor? The AC inhibitor here given to you is captopril. So scleroderma renal crisis, please remember you need to give AC inhibitors, right? And at this moment you should know what are the antibodies as well, because it's an autoimmune disease, right? Now in limited scleroderma, the antibody is anti-centromere antibody, right? Anti-centromere antibody. Whereas in diffuse scleroderma, the antibody is anti-topoisomerase antibody, right? Anti-topoisomerase antibody. So that is in case of diffuse scleroderma. So in localized or limited scleroderma, anti-centromere. In diffuse scleroderma, it is your anti-topoisomerase antibody. Right? So that is about your the antibodies, like what you give in case of the the antibodies in case of the scleroderma. Right? So this completes the discussion of your scleroderma antibodies and how do you treat the scleroderma renal crisis. So scleroderma renal crisis, you need to give AC inhibitors. So whenever you give AC inhibitors, there is some degree of renal recovery and not needing chronic dialysis support. Right? Not needing the chronic dialysis support. Okay? Right. Okay. Another very important, the clinical based question. So we have a 57-year-old woman with depression and chronic migraine headache, reports several years of dry mouth and dry eyes. Her primary complaint is that she can no longer eat her favorite crackers. crackers. Although she does report photosensitivity and eye burning on further questioning. She has no other associated symptoms. Examination shows dry, erythematous, sticky oral mucosa. All of the following tests are likely to be positive in this patient except anti-Rho, anti-La, Schimmer's test, SCL70 antibody, and then cytometry. Yes. Tell me, what is the diagnosis and how do you approach this patient? And the question answer is except. Any one of you, what is the diagnosis? Yes, Harish Srinivasan, what is the diagnosis? Very good, Gulu Dugar. So, diagnosis of this particular clinical scenario is Sjogren syndrome. Right, Sjogren syndrome. It is not sarcoidosis, it is Sjogren syndrome. Right? Why? Because if you take this Sjogren syndrome, I'll tell you a few points about the Sjogren's, okay? Sjogren's, it is an autoimmune disease. Right? It is an autoimmune disease. Right? Where you have the antibodies, that is anti-Rho and as well as the anti-La. So these antibodies, they will go and destroy, right? They will go and destroy the lacrimal gland, right? And they will destroy the salivary gland. Right? Now, because they destroy the lacrimal gland, they will have dry eyes. Right? They will have dry eyes. And because they destroy the salivary gland, right? They have dry mouth. And because dry eyes is there, these individuals, they'll have itching and blurring of sensation or burning of the eyes. Right? So there is blurring of the eyes. And because there is dry mouth, there is difficulty in swallowing. Right? There is a difficulty in swallowing in these patients. Okay. So remember, in patients with Sjogren's, it is also called keratoconjunctivitis sicca. The other name of this is keratoconjunctivitis sicca. Okay. Right. Now, the point here is, what are the investigations that you will do in Sjogren syndrome? I said you that you have two antibodies, that is anti-Rho and anti-La. So anti-Rho and anti-La, they are nothing but your SSA and SSB. SSA is your anti-Rho, SSB is your anti-La. And we also do the Schimmer's test. And the purpose of doing this particular Schimmer's test is to assess the lacrimal secretion. Right? It is to assess the lacrimal secretion. Right? And same is your cytometry also. So cytometry, what it will do, this also will assess the lacrimal secretion. Right? This also will assess the lacrimal secretion. So this is about your investigations, what we will do in case of Sjogren's. Whereas, what is the question asked actually? Except, what is the answer? SCL70 antibody. right? So we have the answers from Harish Srinivasan. Only Harish Srinivasan has answered this question. So SCL17, this will be positive in scleroderma. And in scleroderma, you don't have this type of the clinical picture at all. Right? This type of clinical picture will not be there in case of scleroderma. Okay. Now, in scleroderma, can you tell me what are the earliest manifestations that can be seen? Any one of you? What is the earliest manifestation that you will see in the scleroderma? So the earliest manifestation in scleroderma is development of Raynaud's phenomenon. Right, development of Raynaud's phenomenon, right? Very good, Guludugar, right? Excellent. So the earliest manifestation in scleroderma is the Raynaud's phenomenon. So initially the fingers will turn into pale in color. Later there will be bluish discoloration, that is cyanosis, and later they may turn into red in color due to reflex vasodilatation. So initially pale in color due to vasoconstriction, then later blue color due to cyanosis, later red color due to reflex vasodilatation of the blood vessels. Right. So the earliest manifestation what you will see in scleroderma is your Raynaud's phenomenon. Right. So this completes the discussion of your scleroderma and as well as your Sjogren syndrome. Yes, this is another very interesting question, and let me see how many of you can crack this. Severe stenosis of the valve shown in photograph correlates with loud opening snap, loud S1, duration of mid-diastolic murmur, intensity of the mid-diastolic murmur. So first of all, please tell me what is the valve which is shown here and what is the diagnosis? Right. So what is the diagnosis in this clinical scenario? So diagnosis in this clinical scenario is, any one of you please? Right, so what is this? This is your left atrium, right? And this is your left ventricle. And this is your aorta, right? This is ascending, this is arch, and this is descending aorta. Very good, Chandrasekharan. So this is a case of mitral stenosis. Now you know the diagnosis, right? Now you know the diagnosis. Now, how will you assess the severity of mitral stenosis? Any one of you? Anyone should at least attempt, right? Without attempting, like, how is it possible for me to discuss? Yes, no one want to make a attempt? Very good, Guludugar. Excellent. So the answer is duration of the mid-diastolic murmur is the one which will correlate with the severity, right? Which will correlate with the severity. So in mitral stenosis, right? In mitral stenosis, there are two things which will assess the severity of the mitral stenosis. Number one, the duration of the murmur, that is longer the mid-diastolic murmur, severe is your mitral stenosis, right? Severe is your mitral stenosis. Now, A to OS gap, right? Shorter is the A to OS gap, right? Shorter is the A to OS gap. Severe is your mitral stenosis. right? Severe is your mitral stenosis. So that is how we will assess the severity assessment of the mitral stenosis. These two parameters are very much required. Now, in the options given to you, what do you have? Duration of the mid-diastolic murmur is there, right? A to OS gap is not mentioned. And in mitral stenosis, the classical murmur is the mid-diastolic murmur, right? The classical murmur is the mid-diastolic murmur, okay, right? So severe stenosis of the valve shown in photograph correlate with the duration of the mid-diastolic murmur. Okay, now see, auscultation in mitral stenosis is very important. Right, auscultation in mitral stenosis is very important. That is, you will have loud S1, right? S2 will be more or less normal. Only if there is pulmonary hypertension, there can be loud P2. Then again you will have S1. So this is your systole and this is your diastole. Right, this is your diastole. Okay, so in the diastole, in the middle of the diastole, you will have mid-diastolic murmur. Right, in early part of the diastole, you will have the presence of the opening snap. Right, you will have the presence of opening snap. And in later part of the diastole, you will have the presystolic accentuation. Right, presystolic accentuation. And that is due to left atrial contraction. That is due to left atrial contraction. So these are the auscultatory findings in patients with the mitral stenosis. Right? These are the auscultatory findings in patients with the mitral stenosis. So the one which will tell you about the severity of the mitral stenosis is the duration of the mid-diastolic murmur. Right? Duration of the mid-diastolic murmur. Okay? Right. You see the next question? Yeah. This is another very interesting question, and let me see how many of you can crack this. A patient with primary Sjogren syndrome that was diagnosed 6 years back and treated with tear replacement for symptomatic relief, and notes parotid swelling is also there since 3 months. And she also has noted the enlarging posterior cervical lymph node. Evaluation shows leukopenia and low C4 complement levels. What is the most likely diagnosis? Amyloidosis, chronic pancreatitis, HIV infection, lymphoma, secondary Sjogren syndrome. What is the most likely diagnosis? Right, evaluation shows leukopenia and low C4 complement levels. Right, so patient is having primary Sjogren syndrome. No. So this patient is having lymphoma. Right, this patient is having lymphoma. Okay, so you see here, lymphoma, it is well known to develop in late stages of Sjogren syndrome. This is a very, very important point. Now, because there is development of lymphoma, you have the leukopenia, cryoglobulinemia, and as well as the low C4 complement levels. Right, low C4 complement levels. And majority of your lymphomas, they are extranodal, marginal zone B cell, and as well as the low grade lymphomas. So these are the lymphomas what you will see in Sjogren syndrome. They are extranodal, marginal B cell, and the low grade lymphomas. Okay, so the answer here is lymphoma. right? So whatever she is having that particular posterior cervical lymph node enlargement, that posterior cervical lymph node enlargement, it is mainly due to the development of your lymphoma. So in these patients with Sjogren syndrome, with associated lymphoma, mortality rate is very high with concurrent B symptoms, right? With concurrent B symptoms. What are B symptoms? Presence of fever, night sweats, weight loss. These are the B symptoms. These are your B symptoms. So mortality rate is very high in patients with concurrent B symptoms. Okay, next. Now we will take up one. Yeah, we will take up one image-based question. Right. So after this, we will wind up the session. So this is the last question for this session. Okay, you see this? I don't know whether you are able to see this or not. Yeah, now it is better for you if I am not wrong. Okay. Abdomen must be compressed for how long for the reflex to appear? So you can see this doctor watching something over the neck and compressing, right? Compressing the right hypochondrium. So for how long the doctor has to compress over the right hypochondrium for the appearance of this particular reflex? Any one of you? Right. So remember, so what is this? This is nothing but the hepatojugular reflex. Right. This is nothing but your hepatojugular reflex. So if you take this hepatojugular reflex, you have to apply the pressure over the right hypochondrium for nearly around 10 to 15 seconds for the appearance of this hepatojugular reflex. Now, when will you elicit this hepatojugular reflex? What is the indication for eliciting this hepatojugular reflex? Let me tell you. So, when there is doubt of incipient right heart failure. What do you mean by the word incipient right heart failure? Early right heart failure. Right? When there is doubt of early right heart failure, you have to elicit this hepatojugular reflex. What you have to do? You have to apply the pressure over the right hypochondrium for nearly around 10 to 15 seconds. And what is that you will notice? There will be raise in the JVP. So if the JVP which is raised, if it is transiently raised, right? If it is transiently raised, then it is normal phenomenon, right? It is normal phenomenon. But the JVP whichever is raised, if it is sustained, right? If it is sustained for 10 seconds, for more than 3 centimeters, right? If it is sustained for 10 seconds for more than 3 centimeters, then this is considered as a positive hepatojugular reflex, right? This is considered as a positive hepatojugular reflex. Now, what is the condition where you will have positive hepatojugular reflex? So you see, in a normal individual, it is negative hepatojugular reflex. That means what? The jugular venous pressure rises only transiently with rapid return to the baseline. This is what will happen in a normal individual. This is what will happen in a normal individual. But in a clinical scenario where you have right heart failure, you will have the presence of the positive hepatojugular reflex. That means the JVP is raised for more than 3 centimeters sustained for greater than 15 seconds. This is what is called as the positive hepatojugular reflex. Right? This is what is called as the positive hepatojugular reflex. Okay? Right. Now, what are the conditions where you will have positive hepatojugular reflex? Left ventricular failure, right heart failure, constrictive pericarditis, right ventricular infarction, and restrictive cardiomyopathy. So these are all the conditions where you have the positive hepatojugular reflex. Okay. So now, for how much time? The pressure has to be applied over the right hypochondrium. The pressure has to be applied over the right hypochondrium for nearly around 10 to 15 seconds in order to elicit this particular hepatojugular reflex. Okay. Now, let me just revise all the image-based and clinical-based questions what we have discussed for today. Right. So, a very important take-home message of this question is that the most common unilateral condition where you have the edema is venous insufficiency. Whereas in pregnancy, you will have physiological edema of both the lower limbs. And in lymphedema, the another name of this Milroy disease is nothing but your lymphedema, where you have bilateral edema in this clinical scenario rather than unilateral. But yes, you can also have unilateral, but bilateral is also seen. But venous insufficiency, that is the most common cause for unilateral edema, right? Next. Now, this is the clinical scenario which we have discussed about the acute rheumatic fever. And what is the take-home message of this question? The take-home message is that for every 21 days, you need to give benzathine penicillin intramuscularly, deep IM should be given. And in those individuals who are allergic to penicillin, for them, you can give sulfadiazine or erythromycin can be given. Okay, this is the take-home message of this question. Now, if you take the next question, yes. This image-based question is about the QT prolongation. QT prolongation is commonly seen in hypocalcemia and hypomagnesemia. Whereas you take in hypercalcemia, you will have short QT interval. You will have short QT interval. Okay, right. Now, yes. Now, this is a clinical scenario regarding scleroderma renal crisis. In scleroderma renal crisis, drug of choice is AC inhibitor. And the AC inhibitor among the options given to you is your captopril. Right? It is your captopril. Next. Now, this is an image-based question related to your Sjogren syndrome. And in Sjogren syndrome, we do anti-Ro-anti-La antibody testing, Shima's test, and as well as cytometry. Whereas Scleroderma 70 antibody, that is what is the test which is being done for Scleroderma, but not for the Sjogren syndrome. Okay. So the question asked is except. So the answer will be SCL70 antibody. Now, you take the next question. Yes. Now, this is an image-based question related to your mitral stenosis. How will you assess the mitral stenosis? Number one, duration of the mid-diastolic murmur. Number two, A to OS gap. These are the two things which will assess or tell you the severity of mitral stenosis. Right? Next. Now, this is a clinical question related to Sjogren syndrome with associated lymphoma. So how can you tell that there is presence of the lymphoma in this patient? That is by your leukopenia, low C4 complement levels, and posterior cervical lymph nodes with a background of history of Sjogren syndrome. So this is a take-home message of lymphoma with Sjogren's. Right, last one. This is about your hepatojugular reflex. And you need to apply the pressure over the abdomen for 10 to 15 seconds for eliciting a positive hepatojugular reflex. And you will have that in case of right heart failure, left heart failure, constrictive pericarditis, congestive cardiac failure, right ventricular infarction, and as well as restrictive cardiomyopathy. So that completes the discussion of both clinical-based and image-based questions for today. So tomorrow again, more or less similar time, we will discuss some more clinical based and image based questions. So thank you very much and see you tomorrow again. Good and stay safe, prepare well, revise well, don't lose your confidence at any moment of time, stay hopeful, that you will definitely clear the exam this time. Okay, thank you very much.